So over the next 10 minutes or so, I'll give you a basic idea of what's new in MCS and cardiogenic shock. We'll divide it up into three principal components: new data, new devices and developments, and then new techniques and upcoming approaches. So going right for the money, the new data is all about danger shock, particularly in the cardiogenic shock space, where this was a randomized trial, the first randomized trial that has ever been positive with mechanical circulatory support for the treatment of cardiogenic shock. This study screened 1,200 patients, excluded 851, and randomized 360 patients presenting with ST elevation myocardial infarction within 36 hours with the presence of cardiogenic shock. Patients were enrolled at the point at which cardiogenic shock developed, and then were implanted with a device in the treatment arm within 6 hours of randomization, with a primary endpoint of the trial being death by any cause at 180 days. And this was a trial of a microaxial flow pump, in this case the Impella CP, versus standard of care, which included inotropes in most patients. And the primary outcome was a pretty impressive separation, which began very early and then continued to separate as you went out past 180 days of randomization, which demonstrated superiority of the use of a microaxial flow pump, i.e. the Impella CP, over standard of care. So this was the first strong evidence that we had, with a number needed to treat of 8, that documented the benefit of the Impella device in the setting of cardiogenic shock in this highly selected patient population that presented with ST elevation myocardial infarction that was complicated by cardiogenic shock. And this is a unique finding, as I mentioned, across MCS trials. MCS trials are very difficult to recruit into because when you are inherently treating shock, you're also treating patients with multi-organ failure, you're treating patients who have had indeterminate periods of loss of reserve, and you're treating often patients with cardiac arrest. And that's been a common criticism of previous trials that have looked at Impella, like IMPRESS, and then of course the ECLS shock and the IBP2 trials, where we looked at patients who were pre-PCI implants, post-PCI implants, late shock, early shock, post-arrest, pre-arrest. It becomes a very challenging group of patients to recruit. And in danger shock, which was an investigator-initiated study, which made it even more legitimate in the eyes of the public, this was a systematically, carefully recruited patient population where if you didn't meet the trial inclusion, you didn't get in. There was very, very small levels of crossover. I think it was only about 3 patients. But what we also learned is that this is a high-risk cohort, and there's no free lunch, right? We recognize that moderate to severe bleeding was high in both groups, okay? And that renal replacement therapy was high in both groups, higher arguably in the Impella group, as was the case for bleeding. But we also recognize that this might have been because these patients ended up getting more intensive ICU care. Indeed, the individuals in the standard care group had a shorter length of ICU stay, indicating that there may have been some degree of survivor bias there. But it's worth recognizing that in individuals within the standard care group who got out of the ICU, the majority of the difference in outcome was actually in the early days. And so it is critical to note that this is about AMI CGS. This is about STEMI cardiogenic shock. This is not heart failure cardiogenic shock. This is not decompensated congenital disease cardiogenic shock. This is not Takotsubo's cardiomyopathy with acute failure, not myocarditis, none of those things. Because all of those disease entities are fundamentally different from a hemodynamics perspective. And that's part of the other reason why this is such a big deal. Because we actually demonstrated not just that there is a device that works in cardiogenic shock, but that if you recruit a relatively pure segment of patients, you can start to answer questions, which is something that we have struggled to do in trial after trial after trial. How about new devices and developments? The nature of cardiogenic shock care, this is a slide from Naveen Kapoor, as are several of these, is that we balance on a razor's edge. What you are trying to do with mechanical circulatory support in CGS is provide support, right? You want to provide circulatory support to the body and unloading to the heart. That's measured by lactate and creatinine, but at the same time, you don't want to make legs ischemic. And so the goal is to try to do this high flow state through the MCS device in the smallest access possible. Because as we demonstrated, there is a very real tax on bleeding and on leg ischemia to the use of MCS devices in shock, particularly in shock patients, because they are also vasoconstricted. They are also the individuals who do not get particularly good flow to their legs, and as a result, they are at highest risk for acute limb injury. And so we are constantly balancing access side and vascular safety with maximal flow and clinical efficacy. And the question is, where do you draw the line? So the ECLS shock trial is a cautionary tale, because even though this trial demonstrated that there was no effective routine ECMO implantation in some individuals who were post-arrest with cardiogenic shock, a very important finding is that nearly 100% of these patients had distal perfusion cannulas. They had 6 or up to 8 French cannulas into the SFA in legs with ECMO. And 1 in 10 of these patients, despite almost 100% of them having retrograde perfusion cannulas, was 1 in 10 patients had acute limb ischemia. And so this behooves us to accept that even in the setting of good distal perfusion, we are going to get acute limb ischemia from MCS device use. And so it is really not a good idea to allow these patients to end up in this spot. And when you look at the Cardiogenic Shock Working Group data set, which is a data set of 7,000 patients across multiple centers in the US, some of which range from the availability of balloon pump all the way to extracorporeal life support and heart transplant on tap, you find that the presence of ALI, the presence of acute limb ischemia, results in an increase in mortality in every type of cardiogenic shock treated. This is what's new in cardiogenic shock. It's not just a heart problem. It's a heart problem, a kidney problem, a liver problem, and now we realize it's also a leg problem. And that is why the breaking of the small bore barrier is actually a really important part of the future of cardiogenic shock care using MCS devices. This is what's new, the recognition that we have to focus here. And as a result, there are a series of devices that have come out focusing on this idea of smaller bore access to deliver larger flow. The Impella ECP, or expandable CP device, the Magenta Elevate device, which is still investigational, and there's the Scheifamed Superior medical device called the Superior device, which is also still investigational, but is now through EFS. The ECP device is meant for high-risk PCI. You're going to hear this as a theme, where it goes in through a 9 French housing and 9 French sheath that is closable with a single angioseal device or a single perclose. And then once it leaves, or once it enters the Impella, it is unsheathed and expands to a 21 French housing that is capable of providing up to 5 liters of support. But because this is not a rigid structure, it does collapse every time the aortic valve closes around it. And that is why it is only designed for 6 hours of support to facilitate high-risk PCI. This is what it looks like when it's being unsheathed and put into the LV. And this has had a number of successful cases across the US as part of their early experience studies. It seems to be very successful. It seems to be a very efficacious device in the setting of high-risk PCI. The same can be said for the Superior system, which is a pump that generates 5.5 liters of flow. So now you're getting into the cardiogenic shock realms, right? Where you're giving almost complete LV-sided support through a housing that's only 10 French, which is amazing if you think about the balance that must place on a pump design, right? High flow equals big size. High flow through a small size equals heavy hemolysis. And in this particular pump, you have very little hemolysis. So there was a lot of really careful engineering that went into this expandable pump. The pump housing lives outside the body, right? This is where the motor lives, and it's in a very intuitive console. This is what it looks like going in, where you have the insertion along your standard guide wire. Once again, you have the unsheathing of the pump after the valve is crossed, and then you have the existence of the device while it's across the valve functioning without much drama. This is the Magna Elevate pump. It is a similar pump that is investigational, once again designed for high-risk PCI. This pump actually releases into an even larger bore catheter, a 30 French housing, through a 10 French access. So sheaths that can be grabbed from on the shelf. They're not special sheaths anymore. And this is all designed to address that access size problem that we have so clearly demonstrated over these 7,000 patients in various shock registry studies. The Magna Elevate does a very good job of maintaining mean arterial pressure across all of the patients that were treated. And this is what it looks like when it's being resheathed. It's not all that complicated. You just pull the darn thing back into the sheath and you take it out of the body. So one can understand how attractive this must be as a solution. The problem is high-risk PCI is not cardiogenic shock. These are not the same entity. And as a result, we recognize, and this was very nicely illustrated in this table by another slide that I borrowed from Naveen, that there is no free lunch here, right? This is a very challenging balance. And so there's going to be a lot of innovation and a lot of engineering put into these pumps, and a recognition that it's probably best when you implant these pumps as early as possible, particularly when you're using expandable devices, because you don't have the same duration of support through these types of pumps. And PHP was a very cautionary tale in that regard, with clot developing in pump housings and embolus throughout the body. So the last piece is new techniques and new approaches. So far, we've concentrated on the function of the pump. But what happens when you start to have challenges with a pump not giving you enough? Are there things that you can add into that paradigm to try to get yourself a better result? So the first thing is, how do you prevent bleeding and acute limb injury when you're using the pumps that we have? Well, this is the Impella side closure technique. Okay, and this is from I can't remember his first name now, Dr. Wilson, who's located in the United States. The way they do this is they place an 035 wire through the side sheath of the pump. And this isn't someone who already has 2 percloses put in, but is still bleeding. Then you, with that 035 wire, you back out the repositioning sheath while an assistant holds pressure. So now you have an 035 wire through your access sheath, or through your access hole. You then place a perclose device along that 035 wire, and you effectively cinch the tip of your arteriotomy. You put a third perclose down, but just on the tip of the arteriotomy. Often the bleeding occurs in these types of accesses because they become oval, because you're bleeding either behind the sheath or above the sheath, or because the repositioning sheath, which goes from 13 to 9 French, just isn't big enough when you hit the arteriotomy because the patient is very large. And so this is a way where you can actually place a third perclose on top of the vessel without having to take the Impella out and without losing your access, where once the perclose is put in, you're able to tighten down the perclose around the Impella catheter at the level of the arteriotomy. And then once that perclose is tight, you replace the Impella repositioning sheath through the arteriotomy that is now a little bit smaller than the 14 French you used to put it in. And as you'll see, in this previously bleeding arteriotomy, you take pressure off once the Impella sheath is repositioned and there's no longer bleeding at the access site. So this is as good as single access, right? This is a major advent in the way we manage the vascular access associated with this device. And I think it's going to catch on, but like everything else that we learned from Twitter, it's going to take some practice, right? And then the last bit is, what does it look like when you start to innovate, when you start to combine MCS technologies? This is from Naveen Kapoor as well, using the device formerly known as Precardia. This was bought by Abiomed as well, where it's effectively a balloon that gets inflated in the SVC. And what that does is control right heart filling and right heart pressures, and therefore systemic venous pressures that drive the venous segment of cardiorenal syndromes. And when you combine an Impella, which is the left-sided support device, with management of RV filling using this Precardia device that's placed in the SVC, what you actually get is a change from an Impella PV loop where you've unloaded the left side a little bit and you've reduced the PVA, the amount of work the heart's doing, to a dramatic reduction where you actually flatten out the diastolic filling curve and you reduce the amount of work that the heart is doing. So by combining these therapies, and there's a variety of these, there's neuromodulation to reduce heart rate, to decrease the amount of oxygen utilization from heart rate versus just the preload and afterload that the Impella is able to manage. When you combine these therapies, you actually get a reduction in the amount of myocardial stroke work. And that is really what we try to achieve in the treatment of the cardiogenic shock patient. And so with that, I'll thank you for your time and attention. That was a whirlwind tour of what's new in this space, and I'm happy to answer questions.